Okay, so let's get started. Thank you everyone for coming. Sincerely appreciate it. Today, I think we have a really exciting talk planned, very interesting discussion. Really looking forward to hearing from the audience today. Please, if you have any questions, put them in the chat. If you have anything you want to say, please raise your hand. We would love to hear from you today. We want this to be incredibly interactive. So this is the August 13th Molecular Tumor Board, where we're going to talk about KRAS and really emphasize revolution medicines. My name is Basim Gwele. I'm accompanied by Ram Subramanian, Silambarsan Maskamani, Bhadresh Rami, and Ali Ukar. These are our disclosures. You can see them here. And this is what we're going to be talking about today. This is our overview. So we're going to be talking about KRAS in general. We're going to talk about Revolution Medicine's pipeline. We're going to talk about non-small cell lung cancer. We're going to basically talk about other KRAS variants, and we're going to have concluding remarks. So we're going to start with a poll question today. I really want to talk about what people think about in terms of P53 versus KRAS versus the other, well, and to see what people think is better, what's more important in terms of targeting. Having a little bit of technical difficulties here, so just bear with me for a moment. So we're going to launch this first poll. So which do you feel is more important to target? Do you feel it's KRAS, P53, or is it all the same to you? Okay, so we'll end the poll. So it looks like everyone feels like KRAS is more important to target. I think that's completely legitimate in 2022 on August 13th. So when we talk about KRAS, I think it's important to know that there are 3 genes for RAS in general, the RAS family. So there's HRAS, NRAS, and KRAS. They encode for 4 proteins. So they encode for HRAS, NRAS, KRAS4A, and KRAS4B. When we talk about KRAS mutations, we're really looking at KRAS4B. So KRAS stands for the Kirsten-Rat sarcoma viral oncogene homolog. You can see here, it's basically either 188 or 189 amino acids, depending on which isoform that you're talking about. And here you can see it's largely comprised of 30 kilobase DNA with 4 exons. It's mutated in about 30% of human cancers. So everyone in this room really very interested in KRAS, and rightfully so. When we talk about KRAS, and I know that we're talking about the biochemistry here, but I think it's important just to appreciate a little bit. We talk about KRAS, there's a G domain, which is really the catalytic domain, and a hypervaluable region. So I think that's important just to recognize when we talk about how we target KRAS today, really going to focus on the G domain. And so when we talk about the G domain, there's a P loop, there's a switch 1 region and a switch 2 region, and they're actually basically depicted here. And what's really important to know, and what we really need to consider, is that RAS is really a G protein, right? So everything we're going to talk about when it comes to RAS is whether or not it's bound to GDP or GTP. It's a G protein, so that basically means that when it's bound to GDP, it's inactive. And when it's bound to GTP, here in yellow, it's active. And so everything you're going to hear about today is going to reside on whether or not RAS is in the GDP off conformation or the GTP on conformation. Critically important. Everything about RAS comes down to the fact that it is a G protein. Now, when we talk about RAS GDP, when we talk about RAS GTP, it's critically important to recognize that we have the guanine exchange factors, so GEFs, and we have GTPase activating protein gaps. And what does that mean? Well, the GEF basically facilitates exchange of RAS GDP to RAS GTP, basically exchange of GDP for GTP. So conversion of RAS GDP to RAS GTP. The gap, the GTPase activating protein, basically enhances GTPase activity, thereby converting RAS GTP to RAS GDP. A lot of what we're going to focus on today is really the state of RAS. Is it in the RAS GDP form or the RAS GTP form? And what are the proteins involved in regulating that? Everything we're going to talk about today, when we talk about KRAS, all the inhibitors you're going to hear about, they all have to do with this. So many people in this room, pretty much everyone in this room, knows that KRAS is a central protein in cell proliferation, in cell cycle progression, in cell polarity and movement. KRAS is where it's at, right? It's why it was the holy grail. It's why everyone's been chasing KRAS. It was first discovered in 1982. It's why everyone's super excited that now we have inhibitors for KRAS G12C. So KRAS, as you know, is activated by growth factors, chemokines, calcium, receptor tyrosine kinases, and all of these different activating pathways essentially promote conversion of RAS GTP to RAS GTP. What we oftentimes think about is the receptor tyrosine kinases, whether it's EGFR or it's PDGFR or FGFR or it's HER2 or VEGFR. And what essentially happens there, right, is that when you get activation of the protein by the ligand or through mutation with constitutive activation, you essentially get homo or heterodimerization of the receptor tyrosine kinase. That basically leads to autophosphorylation. That phosphorylation recruits GRB2 to the membrane, which is an adaptor protein, which recruits SOS, which is a GEF, right? It's a guanine exchange factor, so it's a GEF. And basically through SHP2 can also enhance conversion of KRAS GDP to KRAS GTP and basically activate it, which then leads to MAP kinase activation. That's here. So you can see MAP kinase is ERK, and that's a central pathway for us in terms of basic life. It can activate the PI3 kinase pathway, phospholipase C, which many people forget. They don't really think about the fact that we're really activating phospholipase C when you get activation of receptor tyrosine kinases. And that's essentially what we're seeing here. You can activate other pathways as well. So the key here, and what's really important to appreciate, is number one, GRB2 is an adaptor protein. We talked about that. SOS is a GEF, right? It facilitates conversion of RAS GDP to RAS GTP. And that's really important because a lot of people are targeting SOS. You're going to hear about SOS1 inhibitors. That's why they're targeting SOS1, because they're trying to prevent the conversion of KRAS GDP to KRAS GTP. And if you'd actually just take a step back and think about that, right? When we talk about all of these different KRAS mutations today, we talk about G12C, we talk about G13C, we talk about G12D, we talk about Q61H. When you think about these KRAS mutations, it's important to realize that if you're targeting KRAS specifically, well, that's going to be very inhibitor dependent, right? You have to have the right inhibitor for the right variant. But if you target upstream, if you target SOS1, now you have a drug that might work on all of the KRAS variants, which is why everyone's going upstream to target KRAS. In addition, we're going to talk about SHP2 inhibitors. We're going to talk about inhibitors here today, because again, people are trying to target upstream of KRAS. Now, they're not really doing that as single agent therapy. They're doing it oftentimes in combination with KRAS inhibitors, but that's the reason. That's why knowing these pathways is so important. So, a lot of people talk to us about, why are we talking about the biochemistry? Why are we talking about the pathways? Well, there's going to be a ton of drugs thrown at everyone, pharmacists, oncologists, and the like. And if you try and memorize drug name without understanding mechanism, it's going to be really challenging. In addition, in the future, when you're taking care of patients and trying to devise the best combination strategy, or you're trying to devise the best combination trials, you really have to appreciate the pathways. You have to understand what the pathways look like. And so that's why we're really focused on it today. Now, SHP2, that's located here, is an activator of KRAS, actually a direct activator of KRAS through dephosphorylation, right? And so through its phosphatase activity, this gets a little complicated, but I will just say that SHP2 dephosphorylation facilitates RAF binding and allows KRAS to really promote RAF activation through the MAP kinase pathway. So it's important. It also seems to have a scaffolding effect for SOS and GRB2, putting them in the right position to interact with KRAS GDP, converting it to KRAS GTP. And so that's critically important to know. Neurofibrinogen 1, NF1, is actually a gap that's not depicted here. But what I think is really important to know there is that neurofibrinogen 1, which is a GTPase activating protein, facilitates the conversion of KRAS GTP to KRAS GDP. So it basically turns it off, right? And why is that important? Why do we care? Well, number one, we use a drug called selumetinib, which is a MEK inhibitor downstream of KRAS in neurofibromatosis, right? So neurofibromatosis is where you have a mutation in NF1, you get activation of this MAP kinase pathway. So how do we target? Well, we use selumetinib in those patients. In addition, if patients have loss of NF1, if they lose the RAS gap, what you basically have is you have an increase in KRAS GTP, the on form, because you don't have the gap turning it off. And so if you look at molecular profiling, lots of people will do this, you'll see an NF1 loss on the molecular profile. So the reflex is to say, hey, you can use a MEK inhibitor like binimetinib, cobimetinib, trametinib, or sulimetinib. And so you will oftentimes find that in the molecular report, when you're doing molecular testing, when you see an NF1 loss, the reflex is to put a MEK inhibitor there, and that's why, right? Because we know that MEK inhibitors help with neurofibromatosis, and we also know that if you have NF1 loss, it may be somewhat useful. Now, I don't think it really holds true clinically. I don't really use MEK inhibitors that much solely for NF1 loss on my patients, but it's important to recognize. Now, when we talk about KRAS mutations, it's important to realize that each tumor type has a different frequency of KRAS mutation. So you can see here that in pancreatic cancer, there's a very high prevalence of KRAS mutations. Roughly 90% of pancreatic cancer patients have KRAS mutations. Roughly 50% in colorectal, roughly 25%, some people say 15, but 15 to 25% of patients with lung cancer, about roughly 25% of small intestine. And so you can kind of see that the frequency of KRAS mutations depends on the tumor type. Not just that, but the actual KRAS variant profile depends on the tumor type as well. So in pancreatic cancer, you see a predominance of G12D mutations, which we're going to talk about later. You also see G12V mutations, but you can see very little G12C. Well, I shouldn't say very little, but a minority of patients have a G12C mutation. In contrast, if you look at non-small cell lung cancer, the vast majority have, well, a significant number have the G12C variant, which is why everyone's using that KRAS G12C inhibitor in lung cancer, because there's a predominance of KRAS G12C mutations in non-small cell lung cancer. Just for completeness, I will say that if you look at colorectal cancer, about 28% of them have a G12D mutation, about 26% roughly, or 20%, sorry, have a G12V mutation. So that's important to recognize. Now, another thing that's, I think, important to realize is that most often the KRAS mutations are single missense mutations, and they're in certain codons, right? They basically affect G12, or they affect G13, or they affect Q61. And that's really important, right? Because I should say amino acid here, not codon. But the bottom line is G12, G13, and Q61 are intricately involved in GTP association or GDP association with the protein, and also incredibly involved in binding with GEFs and with GAPs, and really regulating KRAS GDP versus KRAS GTP states. So that's why these mutations are incredibly important. Now, one thing I think is interesting to know is that KRAS is oftentimes co-mutated with other genes. So you can see p53 is actually pretty common, 39.4%. We talked a lot about p53 last week or 2 weeks ago. We talked about how PMV Pharma is targeting p53. We talked about the Y220C variant, but obviously p53 is critically important in oncogenesis. You can also see that KRAS is co-mutated with MET. It's co-mutated with STK11 and KEAP1, co-mutated with ATM and SMARCA4, ROS1, etc. So this is important to realize. And so I think that just know that KRAS is frequently co-mutated, and that we're going to probably be doing a lot of combination therapy based on this. When we talk about KRAS activating mutations, the key here is to just recognize that they really promote the KRAS GTP state. Everything about KRAS goes back to the fact it is a G protein, active in the GTP form, inactive in the GDP form. So a lot of these mutations will inhibit the intrinsic GTPase activity of KRAS. So KRAS has some intrinsic activity where the GTP is basically hydrolyzed to GDP. And so you get KRAS GTP to KRAS GDP just based on intrinsic activity of KRAS itself. But these mutations not only impede that process, but they also impede the association of the gap, the GTPase activating protein, with KRAS GTP. So you don't get conversion of KRAS GTP to KRAS GDP at the level you should. You can see that they typically affect the amino acids at 12 and 13, replace glycine with other bulkier side chains. They prevent arginine residues in the gaps from triggering GTP hydrolysis. So let's talk about that. So if this is the gap, okay, here's the arginine finger. And the arginine finger needs to associate with RAS, with KRAS, to facilitate conversion of RAS GTP to RAS GDP. So what happens when you get these mutations is they impede this association of the arginine finger of the GTPase activating protein with KRAS itself. And you can see that depicted very nicely here. Here's the GTPase activating protein coming to convert RAS GTP to RAS GDP. Here's the arginine finger that's necessary in that process, typically interacting with the glycine at position 12 of KRAS and other different amino acids here. But you can see very critically that this association is imperative to properly regulate KRAS activity and to properly take KRAS GTP to KRAS GDP. And what's really interesting is that these different mutations we see, the G12 mutations, the G12A, G12C, G12D, et cetera, G13, Q61, they all have differences in their sensitivity to the gaps. They have differences in their metastatic propensity, so where they typically spread, and difference in terms of how they bind effectors. So these are not created equal. KRAS G12C is very different than KRAS Q61H. And so that's really important to recognize. And much of what we're going to talk about today is these variants. I mean, lots of people know KRAS G12C. We're not adding value talking about KRAS G12C, although I do think that we have some tremendous things to show you today. But where we will really add value today, I think, is talking about KRAS G12D, KRAS Q61H, and the like. So this is just basic biochemistry. I'm not even going to go through this. All I wanted to show people, right, is when we talk about the conversion of G12 to C and G12 to D and all these mutations, it's not hard to realize the impact this would have on a protein, right? You're taking glycine with its hydrogen side chain and you're converting it to cysteine with a thiol group, right? Or you're converting it to aspartic acid and you can see the carboxyl group. These are very different, right? I mean, they're classically different in terms of the side chain, and you can obviously see that this would likely have an impact on function. So not surprisingly, when you actually look at the putative structure and you look at what's happening, you can see that here's the arginine finger of the gap that we were talking about, right? And you can see that this cysteine residue and the thiol group is causing an issue with the association of this arginine finger with the protein. Similarly, if you look at the G12D variant, you can see the aspartic acid here also causing a problem. Here's valine, you can see causing steric hindrance. Here's the aspartic acid of the 13 position, again, causing steric hindrance. And here's the histidine residue of Q61 causing steric hindrance, precluding this arginine finger from properly associating with RAS. And so that's how it works. That's the behind the scenes, not complicated, although I will say very complicated for people to figure out, amazing what people have done, but showing it like this, not that complicated to understand conceptually. So with that said, I'm going to have Bhadresh talk about how we target KRAS G12C.
Thanks, Basam. Hello, everyone. So what we are seeing here after that excellent introduction is the two molecules that are currently in clinical trials, and some of them more to follow. But these are the two front runners, sotorasib and adagrasib. From one is from Amgen and the other one is from Mirati. These are specifically targeting the occurrence of cysteine as a substituent for glycine on the P loop that Basam showed earlier. And P loop, as you would appreciate, is a highly flexible part of the KRAS protein, which also interacts with the effector protein, that's the GEF protein, guanine exchange factor protein. The presence of cysteine is one of the most nucleophilic amino acid, the cysteine thiol group. And to hit that, these molecules have been designed by using an equally electrophilic warhead to combine with the nucleophilic cysteine thiol. And then using fragment-based drug discovery, these molecules were assembled. And what we see here is the KRAS proteins, normally they do not have active site inhibition. If you see in the picture below, there are different pockets. The green one that's the nucleotide, that's the GTP. But a little distance away, kind of an allosteric site, is where the inhibitors bind, because the switch 2 pocket, that's the switch 2 pocket in which these bluish purple inhibitors are docking, that opens up upon GDP binding. And that allows this small molecule inhibitors to dock in. And because of this electrophilic and nucleophilic attack on the cysteine thiol, these molecules covalently link to the cysteine. So we are talking about a permanent chemical modification of the KRAS protein. It will never leave, the inhibitor never leaves the protein until it is naturally recycled in the body, which means we are talking about long-term inhibition. And these molecules are very active on G12C. And they also bind in the GDP form. What eventually happens is, once they bind to the GDP form, that bound form reduces the affinity to the guanosine exchange factor. And because the protein is naturally recycling between GTP and GDP form, whenever the protein turns back to the GDP form, the molecule goes ahead and locks the cysteine, reacts with the cysteine. So over a period of time, in a few hours, all the KRAS G12C protein in the body is eventually chemically modified by these inhibitors. What is important to note, which we will touch on later, is because of the chemistry behind designing this molecule of going after the cysteine thiol group, these molecules are not effective on the other mutations that happen at the same position. That's the G12 to aspartate and G12 to valine, which are much bulkier groups and of a different chemical nature. We'll talk about one of these mutations later on in the presentation once we go through the G12C clinical profile. Thanks.
So Dr. Subramanian will talk about KRAS inhibitors in the clinic.
Thank you, Bhadresh and Basan. So we'll look at what is the clinical data with these KRAS inhibitors, particularly the two drugs, sotorasib and adagrasib. And as Bhadresh mentioned, that they are targeting specifically to that cysteine residue in the G12C KRAS mutation. And there are two clinical trials. One is the Crystal-1, which evaluated adagrasib in patients with non-small cell lung cancer. The other one is CodeBreak 100. And these drugs are now, we are using this very regularly in the clinic. As you can see, the response rates for both of them is approximately 40%. And both these studies had over 100 patients. And you can also see that the disease control rate was as high as 80%. Now, one of the things that we need to keep in mind is all of these patients were receiving this drug after they had failed at least frontline chemotherapy treatment. So, and many of them actually more than one line of treatment. So this is a very treatment resistant population. So the response rates of around 40% is quite impressive. And we'll be looking at some of the clinical data in comparison, and you will see why. And you can also see the median PFS ranges around 6.5 to 6.8 months, and the overall survival slightly over 1 year. And you can see the bullet point in red that talks about intracranial metastases, because this is very important. We know that patients with brain metastasis do poorly, and this drug has the ability to penetrate the blood-brain barrier and has a 32% intracranial response rate as measured in 19 patients from the Crystal-1 trial. So we have a poll question here. What do you think of this data? I know many of you have already been experienced in the use of targeted therapies as well as emerging therapies. So what do you think? Is it something great? So, not impressed? Okay. So, Basan, do you want to talk about the poll results? There we go. Most of us say, half of us say great, a third of us say so, and about 17% not impressed. And that's not surprising. You know, the response rates that we see here are definitely good, an improvement in over standard of care, but we still have a lot of work to be done here. So I'm not surprised that half of us feel it's great and the rest of us not so impressed with it.
So, you know, we all stand on the shoulder of giants, and even Isaac Newton, who was a world-renowned genius and one of the smartest people in history, will tell you that he stood on the shoulders of giants. But the question is, what happens when the giants decide to build their own company? So here's Kevin Shokot, who I think many people will credit with transforming KRAS inhibitors in this entire field. And they decided, along with Dr. Fishbach and Dr. Burke, who are also brilliant, that they wanted to build their own company. So they're the academic founders of Revolution Medicines, who we're focusing on today. They are a company really focused on KRAS and this pathway. They do a little bit of mTOR, as you can see, mTOR1, but they are fixated on KRAS and they are tremendous at it. So it's very interesting. They have a RAS multi-inhibitor, so that it actually inhibits various variants of KRAS or RAS in general. They have a KRAS G12C inhibitor, KRAS G12D, KRAS G13C, and you can see here they also have a SHP2 inhibitor, which we'll talk about later, and a SOS1 inhibitor. So they are fixated on this pathway. They are a very impressive company. They're something to definitely watch and a company to look out for. When we talk about the different inhibitors they have, you can see they're targeting KRAS and RAS in general in multiple ways, right? They're going upstream of KRAS, and so they're really looking at SHP2 and SOS1, like we talked about earlier, and they're also really targeting KRAS. But what makes them unique is, as opposed to adagrasib and sotorasib, which we just discussed, that really target the KRAS GDP bound form, they target the KRAS GTB bound form. And that is, I think, what makes this company incredibly unique, and it's a very intriguing phenomenon. Bhadresh will talk about these drugs in particular.
Yeah. Thanks. So I think, as Bassam mentioned, this is indeed a revolutionary advancement in the field, and no wonder this is a first-in-class inhibitor. The biggest difference here is twofold. One is most of the inhibitors till now that required the protein to be in the GDP bound form for the inhibitor to act, because in the G12C, the two molecules we discussed, sotorasib and adagrasib, they bind to this protein, covalently link the cysteine in the RAS GDP bound state, that's the off state, when the protein is not active. But in doing so, they are missing that a large population of the protein which is also still active, that's in the on state, the GTP bound state. These molecules are unable to act. What Revolution Medicines have done through this molecule RMC-6236 is a first-in-class potent oral RAS selective tri-inhibitor, but in the on state of RAS, that is when RAS is bound to GTP. So we don't know the chemical structure of this. The structures shown below are from an earlier publication, so it's kind of an indicative of which direction they would have taken. But as you could see from both from the chemical structure and the little dumbbell shaped in between in the cartoon, this molecule is a bifunctional molecule. One arm of the molecule selectively binds to KRAS in its GTP on state. So it essentially is inhibiting the active form of KRAS. And remember, as Bassam described earlier, it's the active form of KRAS that's involved in all the growth proliferative signals that happens in the cancer cells. If you directly block the GTP on state of KRAS, you can have the maximal impact. But what additional thing this molecule does is the second arm of the dumbbell on the right side. It has a significant part of this molecule binds to a cellular chaperone that exists in large quantities in the cell, shown here as CYP-A or cyclophilin A. Together, they form a complex KRAS cyclophilin A. It achieves two things. One is it blocks KRAS in the on state and therefore prevents the downstream signaling. But as a double whammy, it also prevents the interaction, the large molecular interaction between KRAS and its effector proteins, the RAF protein, which is a kind of a GTPase activating protein. It's one of the gap proteins that activates hydrolysis of GTP. So through binding to cyclophilin and KRAS on state, it's also achieving a downstream inhibition of interacting with the GTPase effector protein, which would help KRAS recycle GTP. So essentially, you are locking at two positions, right on the target and one step below. And that is very hard to come out of in terms of mutations. So this is the the major advancement in the field. It's a terrific scientific achievement, because it's a very unknown mechanism. It's first time coming to the field, and as we will see later on, this is active against multiple KRAS mutants, not just K12C or other ones, because of its unique mechanism of action, as shown on the bottom right, G12V, G12R, G12D, and wild type, and including the other mutations at glutamine position. So it's really a mutant allele targeting mechanism, and we are really looking forward to the clinical data from this. How it proceeds to late stage clinical trials. And this is the molecular profile of this, what we showed as a tri-molecular complex RM6291. This is a next generation in the revolutionary medicine portfolio. it inhibits the downstream signaling for phospho-ERG and other molecules at sub-nanomolar potency. You can see here it's a very, very strong covalent binding target with high selectivity only in cells that express the RAS mutants. You will see it's very weak on RAS wild type cells, so we are expecting poor off-target poor off-target toxicity in this case. And the other safety screens are also clear. It's a reasonably low to moderate bioavailable molecule from its PK profile. And as you can see on the right, in terms of its tumor responses, it's a very good 68% ORR. And this is just the beginning. I think as they have more molecules with probably better PK PD profile coming in, and as you will see here in the selectivity, it's forming a covalent bond. So it's a covalent on state inhibitor, which also prevents the downstream signaling through the GTPase activating domain gap activation. So it's two-step inhibition, and that's also showing up in the tumor responses in the xenograft model. So really fingers crossed for this mechanism. We will see more as we go forward.
So, there's a lot of companies targeting KRAS G12C, not just Revolution Medicine, not just Amgen, not just Mirati. A lot of companies in this space, tremendous companies, tremendous players. So Johnson & Johnson, Eli Lilly, Ventus Bio, Genentech, with some recent data I'll talk about in a second, Novartis, Boehringer Ingelheim. Now, interestingly enough, Eli Lilly's drug, that trial was actually terminated due to toxicity. Genentech just published tremendous data on GDC 6036, which is a KRAS G12C inhibitor that had an overall response rate of 53% with an N of 57 in that trial. So stay tuned for this particular drug, GDC 6036. They're going to have something to say about this KRAS G12C story.
So let's talk about a clinical case that is important from the KRAS perspective. So we here have a 79-year-old gentleman who's a former tobacco smoker, now presenting with widespread metastatic disease where the primary appears to be in the lung. And as you can see on the PET scan, you can see that there's very diffuse disease. You can see on the right side lung, you can see multiple tumor nodules, and then you can also see in the right side on the PET scan, you can see the metastatic disease that's kind of involving the chest wall, and subsequently on the liver, you can see that significant amount of disease burden. So the standard of care approach would be to do a molecular testing on this tumor and then start treatment. And this patient, because they did not have some of the classical drivers, was started on an appropriate frontline regimen with carboplatin, pemetrexed, and pembrolizumab. But before that, the question is, what did we see on the biopsy? So here you have the right lung CT-guided core biopsy sample. And as you can see, I think in one of my previous presentations, we talked about looking at pathology specimens, and blue is bad. But what's interesting here, pink is bad, blue is okay. You can see a lot of pink, but at the same time, you can also see in the center here, you can see some of these areas, which is almost like flat layers of protein which stains pink, which is essentially the necrosis. So this tumor had extensive necrosis, and this is not uncommon to see sometimes in patients with lung cancer. And sometimes there is so much necrosis, it makes it difficult to call it a malignant tumor. So you may have to repeat a biopsy, which was done in this case. Even though this core biopsy was suspicious, you do sometimes have to repeat the biopsy. And what you see here is that, you have a confirmed diagnosis of lung cancer, and on top of that, you test for TTF1, thyroid transcription factor 1, which is a marker for tumors of lung origin. And that you can see is shown as a brown stain in the second slide on the right side. And it's not diffusely brown, but there is enough to be consistent with TTF1 positive lung origin tumor here. And then we have the molecular testing results here. And there are several findings. The first obvious finding is the presence of KRAS G12C. And now we have talked about KRAS G12C and targeting that, and we'll be talking about it again. But as you know, tumors are not necessarily having a single molecular alteration. There could be several others. And the question is, what about these other alterations? Are these significant, and how do we target them? And what we see here, a couple of mutations, one in the ATM gene in the splice site, and the other one CHEK2. Both of them can have a significant role to play in DNA repair. And we know that targeting KRAS with sotorasib is an appropriate option if this patient were to progress on his current line of treatment with carboplatin, pemetrexed, and pembrolizumab. Then you could try sotorasib or adagrasib. But what about this ATM and CHEK2? How do we decide whether these are actionable? Do we target them? Becomes a big question.
Thank you, Ram, so much for this wonderful insight on this one. So, if we look at carefully about this mutation, I think we have discussed so much about the entire KRAS mutation. So, let's put a step back over here. If you look at the entire mutation, as like Basim mentioned earlier, KRAS always can have the co-mutation also. Here, the co-mutation, you can see there is a chance of ATM also coming into the picture over here, right? But I'm going to give some of the caution over here, especially when you are going to order the liquid biopsy. Okay, so we are seeing here two mutations, which is ATM as well as CHEK2. ATM having 3 different variant also available, and CHEK2 having 1 particular variant also available. Right. So what is the caution over here is there is a chance when you are ordering for liquid biopsy, this mutation could have possibly come from the non-tumor cells. So that's the caution. So which means that whether this mutation originally came from the tumor, whether we need to really worry about that mutation or we need to ignore this mutation. That's what the thing is called clonal hematopoiesis. So which means the clonal hematopoiesis is the normal process which will occur while during the aging in the bone marrow stem cells. So a lot of physiological aging process, germline mutations, and then autoimmune disorders, and so many other physiological normal process can induce this kind of mutation, which is in the DNA repair pathway, like ATM, CHEK2, and the TET mutation, DNMT, all these class of mutations can occur in the normal natural aging process. It can be available in the blood sample. So when you compare this with the tumor, you cannot distinguish whether it comes from the tumor or it comes from the normal cells. Okay, so generally the clonal hematopoiesis occurs in 3 different types. One is through the LOY, loss of Y chromosome, basically. Another one is through the chromosome number loss, basically. That's another type. But very important type, which is the 3rd type, clonal hematopoiesis through CHIP. So intermittent potential. So we know that this mutation will occur while during the natural process. Now, as an oncologist or the genomist's responsibility is to find out whether this mutation plays any important role or at least some role in the causing the cancer, or its co-driver along with the KRAS or not. This kind of small questions we need to ask. How to identify that? So first thing, how to identify this particular importance or not? Point number 1, whether these mutations happens while during the hematological malignancy, absence of any cytopenia. The patient don't have any cytopenia for 4 months, but this mutation occurs in that patient population also, which means there is a possibility of CHIP. And also the 3rd one is if the patient having this insertion deletion kind of mutation in the ATM gene or CHEK2 gene or other gene, which have variant allele frequency more than 2%. But if you look at the earlier genomic profile, most of the mutation are having less than 2%. So those mutations we need not to bother about at all, because it could not play any important role in the cancer one, except one mutation which we seen as 3.2%. That could possibly play an important role in the, potentially it could be possibly CHIP. But having said that, you need to validate. Always when you are suspecting some CHIP, clonal hematopoiesis with intermittent potential, you need to confirm this as a CHOP molecule, which have the oncogenic potential. How to do that? You need to always check this one with the tissue testing. So in the tissue testing only, you can identify if the variant having more than 2%, whether it have potential of becoming CHOP or not. So that you need to identify. Other than this, what are the other important parameters this chip molecule or the chip mutation having any importance is that if the chip is confirmed or if the chip is becoming CHOP molecule, if you look at these two diagram, if the mutation occurs in the DNMT, okay, wild type, and the DNA mutation is occurs, what will happen is that it have the potential to increase the tumor and anti-tumorigenicity. So which means that it can possibly increase the resistance also to the mutation, possibly. It stops because of this mutation, the T cell exhaustion can happen. So in order to drive the CT8 positive cells, if this mutation is available, it will include the T cells to allow. In the wild type, the T cells cannot enter, but if it is in the mutated form, the CD8 cells, it can incorporate into the tumor cells basically. That's very simple one. But you have to validate whether it is potentially chip or not. Otherwise, you need to ignore. The same applicable in the TET2 also. So it have to play an important role in two places. One is increasing the anti-tumorigenicity for the immunotherapy, right? By if the mutation is there and it's more than 2%, it will increase the anti-tumorigenicity by the addition of the immunotherapy. And also one more point is that it can play important role in increasing the TMB, tumor mutation burden. So because of this mutation, the tumor accumulation, the mutation accumulation in the tumor can increase. Thereby, it can increase the number of TMB level. All this having said and done, medical oncologist or the treating physician need to be very, very cautious when they are applying for the liquid biopsy. This has been one of the major challenge in the liquid biopsy, that clonal hematopoiesis can occur very frequently among these genes. So yes, this is a summary, entire summary about these two genes. If the mutation is less than 2%, kindly ignore that one. So the third mutation, which we are talking about, the ATM-L2563FS mutation, that mutation is having even though 3%, right? But as of now, today's in the literature, we don't have any known function. What is exactly this mutation does? So when it is called variant of uncertain significance, also clinician cannot take any clinical decision based on this one. So with this context, I would not suggest any of these mutations, ATM as well as CHEK2, having any role in this particular treatment strategy. So that's my summary for clinicians. So from there onwards, we can take it further for the next level. Thank you.
Dr. Subramanian will take over here.
Sorry, I was on mute. I have to remind myself to unmute. So that was a very important input from Silambarasan. And as you can see, as a clinician taking care of patients with non-small cell, you need a team of people to come together. And particularly with our growing understanding of the molecular environment of these tumors, just the clinician alone making treatment decisions may not be enough. We need the help and support of others. So in this particular patient, let's look at the treatment roadmap, the cartography. What are our options and how can we go forward with them? Now we know that we have conventional treatment options, operational, molecular-based therapies, local regional, and then clinical trials. So if you look at the conventional options, in this particular patient, particularly with the KRAS G12C gene mutation, both the drugs, sotorasib and adagrasib, as we saw in Crystal-1, as well as the Codebreak 100 trials that led to their approval, they were all patients who received treatment in the second line and beyond setting. And that's where the approval is. The FDA approval is in the second line and beyond. So the standard frontline treatment for these patients would be a combination of chemotherapy plus an immune checkpoint inhibitor. Or if they are high expressors of PD-L1, 50% or over, you can consider single agent immunotherapy option, such as pembrolizumab, atezolizumab. Also, you can choose an IO doublet here. Now, where is the data for chemo IO? And that's what this table shows here. And there is a list of 7 studies. 6 of them, basically, the first 6 of them is a combination of chemotherapy plus a checkpoint inhibitor. And the last one, Checkmate 9LA at the bottom, is an interesting study where we have chemotherapy plus a combination of nivolumab and ipilimumab, which is a CTLA-4 inhibitor as well. So Keynote 189 in the top row is kind of the archetypal study, and a lot of us use this regimen for treating patients. And you can see that this was focused on non-squamous population. And you can also see the median overall survival for patients getting the carboplatin, pemetrexed plus pembrolizumab was 22 months over the control arm of 10.6 months, and the hazards ratio, as you can see, is 0.6. And if you look further down the table, and if you look at particularly the non-squamous population, which is IMpower 150, IMpower 130, and IMpower 132, most of them have similar, not as high as a median overall survival as we've seen, but anywhere between 17 to 20 months is the median overall survival, and the hazards ratios are similar or slightly higher. Whereas if you look at the Keynote 407, which was in the squamous population, so was the IMpower 131, the second row, and IMpower 131. What you can see there, again, there is benefit to adding a checkpoint inhibitor to chemotherapy, but the benefit is not as high as we see with the non-squam population, which is reflected by a slightly lower median overall survival between 14 to 16 months is what we're seeing, but still statistically significant, and there is an improvement there. Checkmate 9LA is a mix, and it's a doublet immunotherapy plus chemo. It's a different schedule, but it also showed benefit. In selected cases, it can be an option. At least that's what I do in my practice. What about single agent IO? As I stated before, that's specifically in high expressors of PD-L1 expression. Again, the archetypal study that led to the use of these regimens in the single agent was Keynote 24, followed by the phase 3 Keynote 42. So the top row, Keynote 24, you can see that the median overall survival was 13 months, which is quite significant. But again, we got to keep in mind that the high expressors with PD-L1 expression tend to do better than other patients who have lower PD-L1 expression. So it was highly significant. Keynote 42, that looked at patients who had PD-L1 expression from 1% to 100%, but the data that I'm showing here is specific to the 50% or higher, and the median overall survival is lower than what we saw in Keynote 24, but still significantly higher compared to patients getting chemotherapy there. And subsequently, we had the IMpower 110, MPower as well, which also showed single agent IO to be active in the high expressors of PD-L1. Checkmate 227, interesting study. This is the use of a checkpoint doublet here. Again, ipilimumab, which is a CTLA-4 inhibitor, plus nivolumab, which is a PD-1 inhibitor. And you can see that they looked at both PD-L1 positive, and I'm sorry, the lower row, the last row, should have actually been less than 1%. But it's a typo there. But the bottom line again was you can see clearly that there is a benefit in both these populations, whether they're PD-L1 expression positive or negative. There was a significant improvement in the median overall survival, particularly if you look at the less than 1%, which is the bottom row. There is the difference between the median overall survivals in the population is even more significant, which is indicated by a lower hazards ratio of 0.62. So that's our frontline options. So operational in a stage 4 patient, we seldom do, but there is role for focused therapies like surgery, particularly SBRT, oligometastatic disease. There have been studies that have shown in patients with oligometastatic disease, particularly combining SBRT with a systemic regimen does improve outcomes in this group. So this is, again, a decision that you take case by case. This is not something that's you do for everyone that comes in through the door. And the molecular therapy. We've already looked at this. We looked at some of the data, but I wanted here to put it in perspective with what is standard of care prior to the approval of these drugs. And that's the data from the REVEL study in the last 2 rows on this table. REVEL was a phase 3 trial that looked at docetaxel, which was the previous standard of care, versus docetaxel plus ramucirumab, which is a VEGF inhibitor. And there, it was significant benefit in terms of both overall survival, PFS, and ORR. And that led to the approval of docetaxel and ramucirumab regimen. As you can see, the response rate here is 23%, and the MPFS, or the median PFS, was 4.5 months. So docetaxel, as you can see, was even lesser, 3 months and 14% response rate. So that's where we come from. And we had this poll previously talking about, is this data impressive or not, with sotorasib and adagrasib, which has a median PFS of approximately 6.5 to 7 months, response rates of around 40%. From where we came from, I think this is a big jump. But still, in the overall journey for the cancer patient, this is a small progress. So I agree with the poll results, but this is also significant progress compared to what we had previously. In terms of local regional therapies in lung cancer, it's again, SBRT surgery. Some of the others like chemoembolization or cryotherapies, we don't use them as often. Sorry, there's an audience question that just popped up. So the question was, if on genomic profiling, if you have a targetable mutation, will you go for targeted therapy or still use immunotherapy? That's a loaded question. That if we go into that, that'll be an entire lecture, but I'll give a short and quick answer. Generally, the answer is you will want to choose the targeted therapy in most cases, except maybe KRAS and BRAF mutants. You can still go ahead with chemoimmunotherapy first, because they seem to have activity, unlike EGFR or ALK positive patients. But at the same time, we are also learning, as we will be talking about Codebreak 101, there is some interesting data, particularly with immune therapy related toxicity in these patients when we use them together. So it's an evolving area, but generally speaking, for this patient, you can use immunotherapy or immunotherapy plus chemotherapy and then choose sotorasib in the second line. But that may not be the case for other patients with different actionable mutations. So here, I know we talked a lot about the different drugs that are going on. I just wanted to put things in a clinical perspective in terms of what we are looking at. GDC 6036, there will be more discussion about this, is a second generation KRAS G12C inhibitor. We talked about GTP binders too. Now, why is this important? When we talked about sotorasib and adagrasib, the consensus was this is good, but not great. And why is it not good, great? Like some of the other targeted therapies like ALK inhibitors, we think is because it's a GDP binder and not a GTP binder. Because the driver mutation is in the GTP state, and it has to cycle back to the GDP before the drug can bind and hold it down in the GDP state. So there is a slow transition of the GTP bound state to the GDP, which has to happen from intrinsic GTPase activity of KRAS. So it takes time for these drugs to bind and have that activity. So maybe with the GTP binders, we might see better activity and maybe longer disease control. Synergistic approaches, we saw SHP2 and SOS1. I don't want to go into a lot of detail, but there is also some things that we need to look at apart from the pathway-based options. What about chemotherapy? I think one of the questions that came about is, will you choose chemo IO versus targeted therapy in the front line? Maybe in combination with chemotherapy, current G12C inhibitors could be an option in the front line. But then can you combine it with IO? And that's something we'll be talking about. And the ATM splice site and CHEK2, we talked about, could we use a PARP inhibitor? Silamarasan made a very clear point that this is probably a VUS or unrelated, and we shouldn't jump onto a PARP inhibitor in this particular situation. So treatment sequencing, standard of care would be number one, which would be the chemo IO or sotorasib, adagrasib, or a trial. But as these trials progress and we have more mature data, I think already we are using clinical trials in the second line before we jump onto sotorasib and adagrasib, particularly the combination trials of KRAS inhibitor plus SOS1 and SHP2 inhibitors. Maybe we'll have frontline studies, and Basim will be talking about some of these trials and the trials we would like to see in these spaces in the next few slides.
So Ram, which sequence would you choose for this patient?
Right now, I would choose number 2, simply because in the front line, there are not great many studies at this point. So I would stick to a platinum pemetrexed and IO. And there are several studies, including Revolution Medicine studies, where we are looking at SOS1 inhibitor combos with KRAS inhibitors in the second line. I would choose that. Now, of course, if you chose a RAS inhibitor in the second line, you may not be able to use sotorasib or adagrasib. So that's something to be kept in mind. Number 3, I think we still need to make some progress before we get there. So that would be my choice, Basim.
Great.
So unmet needs, we saw a similar pie graph. You can see it's about 40% G12C in lung cancer, and almost 90% are all G12 mutations. The other about 10 to 15% are the other mutations, G13s and Q61s, but the G12 residues are affected across the board, the majority of the mutants in lung cancer. Several approaches have been taken, including KRAS T-cell receptor, antisense oligonucleotide. Those have fallen apart. Some of them have fallen apart, but the tyrosine kinase inhibitor specific to G12C has shown promise. And the non-G12C variants, we did see some of the data from Basim. So what are the studies that are going on? Now, the clinical trial that I would like to, one of the things is chemotherapy we talked about. They're not doing it in stage 4 yet, but there is a new adjuvant study that's ongoing. The pathway-based targeting SOS1 SHP2, there is a ton of studies going on. And this is just an early example of that. There are 12 or more studies happening at this point. So chemotherapy, targeted agents, I think in combination with G12C inhibitors, for sure. What about IO? I think I'll talk about that in the next slide. But what I really want to see is some of the ADCs and other MABs coming up. We'll see if that combo is not yet explored, but remains to be seen, particularly with antibody-drug conjugates and other monoclonal antibodies. So Codebreak 101, this is hot off the press. It just came out of World Lung just a few days back. What they were trying to do was combine sotorasib with immunotherapy, pembro or atezolizumab. And suffice, it's a small study. The biggest problem, it's a phase 1 trial, was hepatotoxicity, significant increase in the liver enzymes. And you can see the rates are 40 to 50% of grade 3 to 4 toxicities. And you can also see that these adverse events led to discontinuation in some subgroups in 50% or more patients. But the investigators, when they presented it, did not give up on this combination. A 50% discontinuation rate is too high. But what they said, if you look at the first column where the sotorasib lead-in was done, where they started with the low dose, started them on sotorasib, and then brought atezolizumab on, the rates of hepatotoxicity were lower, and the TRAs leading to discontinuation seemed to be lower. And a similar trend was seen in the other pembro combination arm, which is the third column. And again, it was a lead-in. So a concurrent approach wasn't great, but a lead-in with the low-dose sotorasib and then bringing the immunotherapy on, closely monitoring it. And in these two cases, where they led in, many of these patients, they were able to get back on treatment after treating them with steroids, and they think they can manage with a lower dose. Small samples, something to watch out for, but more importantly, you can see that the overall response rate was not bad. It was about 29%. And more importantly, you can see the median overall survival was about 16 months. Duration of response was 18 months. So there is activity for this combination. At the same time, there is significant toxicity. So these are early days for this combination. This may fall by the wayside, or maybe the lower dose sotorasib with the lead-in phase followed by the immunotherapy might be an option for our patients, and that remains to be seen. So we have a poll question. What do you think of this LFT data? I'm worried, not concerned, indifferent.
Hold on, I'm just trying to get this poll launched. 1 second.
Dr. Ram, in the time of poll question, can I ask you one more question for the audience?
Of course, please do.
Okay, so like you mentioned, this is very, very exciting data of recently hot from the press that if a patient having the genomic profile with the variant allele frequency, VAF, of having 10% or 15% or 30% of this KRAS, so will the dosage adjustment will be play a very important role based on the variant allele frequency? What do you think? Because if many cells are having KRAS, may we need to increase the dose or decrease the dose? Do you think that that will play important role?
Remains to be seen. Honestly, I don't know the answer to it because the VAF can be tricky depending on what tissue you're looking at, whether it's blood versus tumor. Here we go. We have the poll response, and rightfully so. All of us are worried about this toxicity, and we should be rightly so. I think we should not be ready to jump on this regimen. I think we should wait and see. And to complete the answer to your question, variant allele frequency with biopsies too, I'm a little bit concerned because of where you biopsy and what the tissue quality is. I would probably wait to see before I jump on whether we are just dosing based on variant allele frequency. I wouldn't do that at the moment. I would like to see more data before I do that.
Yeah, I think everything you said, Ram, was tremendous there. You know, I read numerous commentaries on this. I think some people are concerned about that overall response rate being a little bit lower than that 35% roughly they were seeing in earlier trials, and you know, lower than adagrasib's 40+% overall response rate. So like you said, small study, hard to know, but I think the main takeaway there is there's some real concern regarding the liver function test. And so I think that's important. Let's talk about the second patient. It's actually a patient that was sent to us, a 66-year-old female with initial stage 3B non-small cell lung cancer. You can see that here, initially had chemoradiation with curative intent. She ultimately developed new brain metastases July 2021, for which she had CyberKnife. Now, the idea here is that she had a KRAS G12C mutation with amplification. You can see she also had an IRS2 mutation and TP53 mutation, but the bottom line is she was KRAS mutated. Initially in 2020, when she presented, she was local regional disease, stage 3B, and she treated with curative intent, but she did have brain metastases that she developed later on. So initial June 2020, you can see the PET CT here. She gets treated with chemoradiation, concurrent chemoradiation, durvalumab for a year. She then got a new brain lesion, actually 2 new brain lesions, July 2021, for which she had SRS, so stereotactic radiosurgery. She was also put on sotorasib. She actually did not have systemic disease at that time, so she had isolated brain lesions, and the physician at that time put her on sotorasib. Not an unreasonable choice, certainly interesting scenario with just isolated brain mets, no systemic disease, treated with SRS. So I think that treating physician probably thought sotorasib had some blood-brain barrier penetration like other oral drugs that we see, other targeted agents in non-small cell lung cancer. And so, you know, put this patient on sotorasib. So the patient got SRS. You can see some significant swelling here, but things looked a little bit better. January 2022, though, this lesion looks a little bit bigger, and they do a functional PET that shows that it lights up. So there's concern that that actually has some viable cancer there, and there's some progression there. So the patient ultimately got lit therapy, so got laser treatment and also got SRS again. And as they're kind of being treated with sotorasib, now in April 2022, PET CT shows a new intra-abdominal lymph node, shows a new lesion in the left femur. So there's real concern now that this patient is actually progressing on sotorasib, not just in the brain, but systemically. So looks like there's some sotorasib resistance going on here. This patient was then treated with CPP, so chemotherapy plus immunotherapy. So got carboplatin, pemetrexed, and pembrolizumab. And you can see here that the lesion in the belly is, you know, better. You can see here that this lesion in the femur is better. And you can see now, if you look at the MRI, it looks like there's no significant growth, and functional PET shows no significant uptake in that area. So currently in a complete remission, this actually is not, when we looked at the scans, doesn't look like actual malignancy, looks like physiologic uptake. So when we talk about KRAS G12C resistance, which is really important, there's a lot of mechanisms of resistance here. And you can see it can happen at the level of EGFR, where you get kind of mutations in EGFR, SHP2, PI3 kinase, ERK, et cetera. There's just many, many different ways to see resistance, including in KRAS G12C itself. So, you know, Y96D mutation, Y96C, et cetera. So there are a number of potential resistance mechanisms here. Not surprisingly, to try and preempt those resistance mechanisms, there's a lot of combination trials ongoing. So there's trials looking at SOS1 plus KRAS G12C inhibitors, SHP2, et cetera. You can see them all listed here, but up and down these pathways, you see these combination trials, and rightfully so, to try and preempt resistance. One particular trial I want to talk about, also hot off the presses. So that's what we're trying to do with these molecular tumor boards, really give you up-to-date knowledge regarding what's transpiring in the field. So you can see here, SHP2 inhibitor, this is the Revolution Medicine SHP2 inhibitor 4630 with sotorasib in a very small study. 11 patients had very promising data. 3 patients with a partial remission, 4 patients with stable disease. So they had an overall response rate of 27%, but disease control rate of 64%. And very importantly, they saw that they had a 50% overall response rate in pre-treating KRAS G12C inhibitor naive patients. So they had an overall response rate of 27%, but they actually allowed patients to have seen sotorasib before, some of the patients. And what was interesting is in the inhibitor naive patients, 50% overall response, which is actually higher than anything reported so far, but that's just with an N of 11. But be aware that this was a safe regimen, and it's going to be very interesting to see what happens. They actually had 100% stable disease control rate in patients who were inhibitor naive. Additional combination trials, they're up and down that pathway. You can look at this later, but you can see there's a ton of stuff going on with KRAS G12C inhibitors. So what about KRAS G12D? So I'm actually going to turn this over to Bhadresh, but this is where I think we're unique. We're not just talking about KRAS G12C today. I want to shift the attention to the other variants for a moment.
Yes. So what we are seeing here is the new mutation at the same position, glycine 12, but instead of the cysteine that generates a nucleophilic group, we have an aspartate, which has a very different chemical composition. You have the carboxylate group projecting out. And Mirati Therapeutics, through their fragment-based screen and modification of adagrasib at 3 different positions, actually generated the first selective reversible. Now remember, because this is not a chemical modification of the cysteine thiol, there is no good chemistry to modify covalently the aspartate carboxylate side chain. So it is a reversible molecule, unlike adagrasib, and it's of course a non-covalent small molecule inhibitor. The important thing about the mechanism, the difference between adagrasib or sotorasib and this MRTX 1133 is that it acts at 2 levels. One is it binds to the inactive form, that's the KRAS G12D in the GDP bound form, and therefore prevents the cycling of this GTPase, the KRAS protein to the GTP bound competent state. It prevents that or reduces it, slows it down. Therefore, it keeps it in the off state. Although, because it's a non-covalent interaction, depending on the on and off rate between the small molecule and the target, the KRAS protein may still cycle to some extent to the GTP bound form. What this molecule has as a unique mechanism of action is it prevents the binding of the GTP bound form of KRAS to its downstream effectors. That's the GTPase activating proteins, or the RAS binding domain of the GTPase activating protein, gap protein. So because of its dual mechanism of action, it actually inhibits both the active and the inactive form. It binds to the GDP form, prevents it to go to the GTP, therefore keeps it in the off state. If it does go to GTP, then it prevents the hydrolysis of GTP into GDP and PI. Therefore, it prevents the activity of the molecule, and it's therefore very effective. And that's achieved by modifications at the 3 sites. One you see on the bottom right of the chemical structure shown there as the position 2, where it forms a small salt bridge interaction with the glutaminate 62. On the top you see this modification at position number 4, which also interacts with the aspartate at 12 that's coming from the mutation G12D. And on the bottom left of the molecule you see the naphthyl group with a modification compared to adagrasib that enables it to participate in strengthening the hydrogen bond interactions with the rest of the protein molecule. And the data shown in the tabular form below, it's single digit nanomolar potency on the G12D mutant cells. It's highly selective over the wild type. Its PK properties are very good. It's a long-lived molecule in the blood. systemic circulation. Its hERG activity is poor and doesn't inhibit any of the CYPs. So the DDIs are also of very low risk. So it's a very promising development in terms of a non-covalent dual acting reversible inhibitor of glycine 2 aspartate mutation, which is one of the key mutations along with the rest of the alleles that are seen.
Thank you, Bhadresh, for that. So, people are looking at KRAS G12D. We talked about its preponderance in pancreatic cancer. This was hot off the presses, New England Journal of Medicine 2 months ago in June. They looked at cellular therapy. So they looked at CAR T therapy targeting KRAS G12D in pancreatic cancer. This is a patient who had a very nice response at day 85, disease in the lung regressed. You can see the amount of tumor burden regressed significantly. And so I think it's really important to see that this is something ongoing. This is a promising result, and there are ongoing studies looking at CAR T therapy targeting KRAS G12D in pancreatic cancer. Trials we'd like to see with this KRAS G12D inhibitor, right now they're looking at it single agent in various tumor types. MD Anderson has this drug on trial, but certainly metastatic pancreatic cancer, up and down metastatic pancreatic cancer, which is a huge area of unmet need. We'd love to see it first line with FOLFIRINOX. We'd love to see it second line with Gemabraxine. We'd love to see it third line with 5-FU, leucovorin, and Onivide, and even fourth line against best supportive care. We would love to see people use this drug and target that mutation in pancreatic cancer. Now, not just KRAS G12D, but we also have KRAS G13C and KRAS Q61X or Q61H that are being targeted. We're going to skip this a little bit just in the interest of time, but you can refer back to this slide. But please know that there are inhibitors being developed to target these specific mutations as well. So poll question 4, we will skip as well just in the interest of time. But from a concluding remark perspective, please know that KRAS G12C is scorching hot. There are numerous companies going after KRAS G12C, and for good reason. 30% of all tumors expressed have this mutation. We also see, have mutations in KRAS, and we see a preponderance of KRAS mutations in various tumor types, not necessarily G12C, but KRAS in general. There are numerous methods of targeting KRAS G12C. Remember SOS1, remember SHP2, remember all these combination trials. You can refer back to the slide we gave you, but I think it's critically important. I guarantee Revolution Medicines will have something to say about the KRAS field in general. Please be aware that KRAS G12D trials are ongoing. Please think about these other variants, and please reflexively refer these patients for trials. The sooner we find out if KRAS G12D inhibitors are useful, the better off we'll be. The sooner we find out about the other variants of KRAS, and if we can target those with inhibitors, the better off we'll be. So absolutely, this looks like it's driving a lot of tumors. It would make sense in so many different tumor types, particularly pancreatic cancer and the like, we don't have tremendous options to really send your patients for these trials. Look for them. Please look at the variant. The key today wasn't just to update you on KRAS G12C, but the key today was really to make sure you were paying attention to the variants, right? Last 2 weeks ago, the key there was to say, okay, look, we're talking about P53, but pay attention to the variant. It matters. Here we're talking about KRAS in general. When we talk about G12C, everyone knows G12C, but please look at the other variants and really look at the trials ongoing for those. Stay tuned for the new variant inhibitors. With that said, we'll kind of open up to question and answer. Let's take a couple questions if there are any. You can certainly just raise your hand and ask a question if you'd like. And with that said, if there's none, thank you for spending your Saturday with us. We'll see you again in 2 weeks. These are additional references that we did not include in the slides. Thank you very much for your time. Thank you everyone for being here. Appreciate it.
Thank you all. Bye.
Thanks. Goodbye.
Thank you all. Bye-bye.